So in 1987, the PSA test was invented. PSA stands for prostate specific antigen, and it's a blood test that's used for prostate cancer screening, and it's still used today, but it became popular back in the 1990s. It became widespreadly used for prostate cancer screening. And there were a lot of men who were diagnosed with prostate cancer who had their prostate cancers treated with surgery or radiation, and they didn't really need it. And the reason I say that is that most men who are diagnosed with prostate cancer are going to die from something else, because most of the time prostate cancer is found in older men who have a lot of medical problems already to begin with, and it's most of the time a slow-moving cancer that takes years or decades to spread and cause a problem. So most men with prostate cancer don't need any sort of treatment whatsoever, and any treatment that you do, like radiation or surgery, is going to do more harm than good. However, there are some men who are younger or who have a good life expectancy, who don't have a lot of medical conditions, and they have dangerous prostate cancers that can move and spread within months or a couple of years and can kill them. And prostate cancer is still the second leading cause of cancer death among American men, following only lung cancer. So in the 1990s and the 2000s, there were a lot of men who had a lot of morbidity from prostate cancer treatment, surgery or radiation, meaning they had erectile dysfunction, urinary incontinence, a lot of other problems that arose from the treatment of the prostate cancer for these cancers that were never going to cause a problem anyways. So with that in mind, in 2012, the United States Preventative Services Task Force issued prostate cancer screening a grade D recommendation, meaning that there was evidence to recommend against screening for prostate cancer. And this was published, and for a number of years, most primary care doctors stopped screening for prostate cancer altogether, meaning that they said that some men are going to develop prostate cancer that spreads and kills them, but this is rare enough that we don't think it's worth the costs and the risks associated with treating all of these other men. Now, interestingly, that Preventative Services Task Force had 0 urologists on it, and this created a huge outrage in the urology community, and it also caused a significant increase in the number of men who showed up to the emergency room or the doctor with bone pain or some other problem that was found to be prostate cancer that had already spread, and it had spread because they never got it screened earlier. So it's really a controversial subject, but the pendulum has shifted a little bit back towards the middle, where now the recommendation is that for men in the age group of 55 to 69 years old, they should have a discussion with their doctor about the risks and benefits of prostate cancer screening, meaning not that every single man should be screened, but they should at least talk about if they should be screened. And more importantly, in the urology field, there has been a big push towards active surveillance, meaning in the majority of cases, prostate cancer is low risk, and the recommendation is to do nothing other than keep a close eye on it, meaning repeat blood tests, sometimes repeating MRIs or repeating biopsies, but not doing any surgery or radiation for low-risk prostate cancers. And even for intermediate-risk prostate cancers, depending on the patient, sometimes surveillance is recommended if the patient does not have a very long life expectancy. And so the shift in the urology community has been towards treating high-risk cancers in younger men who are likely to suffer from spread of the cancer before they die. So with this sort of intermediate level of management that is more reasonable, not treating everybody who has low-grade cancer aggressively or just forgetting about prostate cancer screening altogether, we've sort of arrived at this place where it's more patient-specific, where we want to treat the cancers that are going to kill people. So with that in mind, the recommended starting age to consider screening is 55 years old. Now, that's not a hard cutoff, so if you have a patient that has any risk factors for prostate cancer, most commonly meaning they have a first-degree relative who's had a significant prostate cancer, or even black men in general with no family history have higher rates of high-risk prostate cancer at younger ages, there's some benefit to screening earlier. And really the only downside to screening earlier is potential false positives, meaning the PSA value is high, but there's no cancer there. And that can lead to unnecessary evaluations, MRIs and biopsies. But if you have a urologist who's able to help interpret the results and determine when we just need to get another PSA in a few months versus do something about it now, there's really no downside in getting that information. It's just a simple blood test. The other factor that is helping the benefit of PSA is that we don't necessarily have to jump straight to biopsy anymore. The MRI of the prostate has significantly improved over the past decade, and it has become a lot more affordable. So most of the time now, people with concerning PSA values or concerning PSA trends get an MRI before they get a biopsy. So the only downside to getting an MRI is the cost of it, and if your insurance covers it, then there's really no downside to getting it. So this problem of finding a concerning PSA trend and leading to an unnecessary evaluation isn't going to hurt anybody other than make them get an expensive test. Now, the other factor that goes in favor of PSA screening is the biopsy itself. It used to be just a few years ago that most biopsies in this country were done with a transrectal needle, meaning a needle that goes through the anus, through the rectum to get to the prostate. And you could imagine that it brings bacteria with it into the prostate, and that creates a major risk for infection. And even with giving people high doses of antibiotics during the procedure, not to mention the side effects of giving people high dose antibiotics, there was still about a 2% rate of sepsis, meaning a serious life-threatening infection from doing a biopsy. So doing a biopsy itself was not without its risk. Nowadays, there's been a large shift towards doing the biopsies through the skin, which carries almost no infection rate. So testing and screening and doing a further evaluation carries a lot less morbidity today. There's a lot less risk associated with testing than there used to be. And finding a low-grade cancer does not necessarily mean that you're going to get an unnecessary treatment. It likely means that you're going to be put on an active surveillance protocol. So there's less of a downside to that. The other end of the spectrum is when the patient turns 70 years old. In theory, they don't need to be screened anymore. That's based on the assumption that they're not going to live that many more years, but that's a very broad assumption. If you have a man in his 70s who's in very good shape, there's no reason to stop screening him. Now in this country, most men, once they hit 70, they've got some medical problems, and you can make an assessment of their life expectancy and the risks and benefits of continued screening, but that's a decision to be made with the urologist. So with all of that in mind, it's something to have a discussion with your primary care doctor or your urologist about the risks and benefits of screening if you're in that age group.